Doctor.
Hello?
Okay, Doctor, can you hear me? Can you hear us?
Yeah, I can hear you.
Okay, welcome to our TCTAP live session. Just thank you for joining us. We have Myung-Ho Jung is co-moderator, and many distinguished discussion is here. So we'll just start, Dr. An.
Yes, so I think it's a welcome to my case rep. And then just before starting my case, I'd like to introduce my team. Besides me is Min-Cheol Kim, and then also another person is Gwangju Min, and then today's IBUS commentator is Professor Hong. So I think today we prepared about the left main, the bifurcated the cases. So I think it's Professor Kim to present in our case, please.
Thank you for introducing. I will introduce today's live case. 59 years old male. His symptom is CCS class 2 angina. He has hypertension and dyslipidemia. Next. 12 ECG showed normal sinus rhythm. No abnormality on chest X-ray. Cardiac CT angiogram revealed significant stenosis and left main and proximal LAD and circumflex ostium. Normal elbow ejection fraction without regional wall motion abnormality. We performed microspec. It showed mild or moderate liver perfusion defect in LAD territory.
So I think as I present about today's coronary angiograph findings, so it's demonstrated some of the critical stenosis is distal left main with also the critical eccentric stenosis in the proximal LAD, and then also the circumflex artery with obtuse marginal branch bifurcated area. And then also we are not sure about in the circles or LAD os by coronary angiograph findings. Can you get some LAO view? This is area quarter in the LAO. So I think it's a circumflex spider view. Okay, so I think it's very difficult for us to the good delineation in the circumflex os and also the LAD os. So I think this patient is very critical stenosis, distal left main, with we think it's some the moderate stenosis in the LAD os and the circumflex artery os, and also multiple lesions in the proximal LAD and also circumflex artery. So I think in this situation, so could you get some comment or discussion about it from the coronary angiograph findings?
Any comment on that? What about the surgery from the panel? Surgery?
It's
no.
one of a good option to do the surgery.
All right. Surgery. What about the surgery from the audience?
Yes.
More than 60 attendees, 60% of attendees want a CABG. All right,
Yeah.
very few. We are all intervention cardiologists. So, why don't you do that, Dr. An?
Well, patient
So I
repeat
think
surgery.
it's because, yeah.
Have we seen the right coronary
So
artery? Sorry? We have seen right coronary artery?
Okay. Please
Pardon?
show right coronary artery.
Have we seen the right coronary artery?
Right coronary, okay. So the previous one.
I think it's important.
I think it's right coronary artery. Is some the moderate eccentric stenosis in the middle artery. So when we calculate the syntax score, I think it's 24. So I think it's if we make a second generation drug-eluting stent with a complete revascularization, I think it's very comparable result to compare with the bypass surgery. So I think we already performed about the IBUS because it's very important for delineation of the circumflex os and then LAD os. So could we present about IBUS findings? So Professor.
Please show us the IBUS image. Okay. Learn. Start. Play. This is mid LAD before diagonal bifurcation. We can see some diagonal branches coming and large amount of eccentric plaque with the spot calcification within the plaque. This kind of vulnerable plaque nature. You can see some echo-free space within the plaque. We are approaching to the proximal LAD. This is minimum lumen area site. MLA is 2.6. We are approaching to the proximal LAD. Large amount of eccentric soft plaque with some calcification, spotty calcium. And this is superficial calcium at 7 o'clock. This is relatively echo-free, disease-free area, proximal reference. This is LAD ostium. We can see some aneurysm formation in proximal LAD os. Proximal LAD minimum lumen area is 3.6. Left main MLA is 4.8. The lesion length is with the proximal LAD is 24 millimeter, and proximal LAD to left main lesion length is about 15 millimeter. And I will show you the circumflex IOS image. This is distal circumflex artery. Obtuse marginal branch is coming at 7 o'clock. You can see a large amount of eccentric soft plaque with echo-free space within the plaque. Kind of vulnerable plaque nature. This is MLA site. Minimum lumen area is 2.8. This is proximal reference. Reference diameter is 3.5. We are approaching to the circumflex ostium. You can see some minimal disease in proximal circumflex artery. We are approaching to the circumflex ostium. Some large amount of eccentric soft plaque circumflex ostium. So I will summarize. LAD, distal reference diameter is 3.0, and proximal reference is 3.5. Lesion length is 24, and proximal LAD, LAD ostium minimum lumen area is 3.6. Distal reference diameter is 4.0. Left main reference diameter is 4.5, and circumflex artery distal reference is 2.75, and proximal reference is 3.5. The lesion length is 30 millimeter.
So I invite
So I think
panelists'
it's,
opinion. And Dr.
So I
Hikiji.
really get some comment from the how can we make a PCI strategy for the left main bifurcate area.
This comment?
So actually, just before.
But
so
and this
LAD
this region is
exception.
very long, especially the distal part of the LAD size is not so big, and the proximal part, especially left main, is 4.5. So many diameter discrepancy remains. So if you
Yes.
implant the stenting, many many types of stent, many kind of stent implanted. So compared to the bypass surgery, this is the finally result. I cannot make a better final image. So I sometimes choose such as cases sent to the surgery team.
Okay.
Yes. So actually, the function, LV function, I think is not so bad, and then also, yeah. So maybe we can try to like PCI also.
Yeah.
And actually, we already performed in the proximal to mid LAD stent implantation using the 3.024 synergy stent, and then proximal the optimization of the high pressure. And then also we already pre-dilated in the circumflex. Can I see the circumflex? Because I think it's before the stent implantation, I pre-dilated in the obtuse marginal branch. So I think this is at present situation, because I think my strategy is we put the stent in the circumflex mid portion, and also circumflex the two stents with LAD, to left main, and then by the reverse T stenting technique.
Okay. Any other opinion from panelists?
3.0면 그 좋을 3.0.
Actually, patient refused bypass surgery. He really wants intervention. So that's why we select this case for live demonstration. It's a challenging case. Okay, keep going on your procedure.
Any other suggestions to how to treat them?
So I think it's right now I just put the stent in the circumflex distal because this is circumflex territory. I think it's quite big enough. So I think it's maybe we have to protect about circumflex artery.
You plan to stand towards the marginal branch?
Pardon?
You plan to stand towards the... Yes. So this is exactly, I have the answer. I think this is a good option because the distal circ, you may not have to put a stent. Just probably open and kiss. For me, open and kiss.
Open the balloon angioplasty.
So, Doctor, what is your plan?
So I think I put the stent in the distal circle, cross the obtuse marginal branch, and then I think it's T stenting, the reverse T stenting, circumflex, and then with the
LAD?
left main to LAD crossover.
Okay. Oh,
So,
okay.
Professor Park, what do you think about that one? Test 해볼까요?
You have already
Why are you going to the distal
balloon,
circ?
balloon inflation for the obtuse marginal branch too, right?
Yes.
So
Because I think it's the angio finding is a very critical stenosis in the. Actually, when we performed in the coronary angiogram, it's somewhat decreased obtuse marginal blood flow was observed. Test.
Why did you change your mind to stand towards the distal circ? Because the circumflex after
Pardon?
the first marginal seems to be not very severely diseased. So personally,
but
I would have
maybe,
standed towards the marginal, simple kiss with the distal circ, and after that probably stand left main to circ. and kiss
So I
to
think
LAD.
I don't want because usually
Because
when
I think we can say even today that the number of stent is a factor of stent thrombosis. So if you do this way, maybe we have to put a stent in the marginal branch also.
I can test. Okay. So okay. Inflate.
Great. Oh, 11.
Okay, deflate. So I think it's inflate again.
Right. 11.
12, 13.
13.
what size? What size?
3.16,
3.0.
3.0, 16,
3.015. And then
16.
It's a
angio.
it's a synergy stent.
good.
Okay.
So I think it's So what do you think about the result of the circumflex with the obtuse marginal branch? 보여줄래요? Maybe.
I think you have, the stenosis is worse now. Is probably a part of carina shift that we see, but also, as usual, certainly plaque shift coming from the proximal main vessel, which is also the rule. So now I will do a kiss, of course, but the risk is that you have to put a second stent. If you look at the pinching of the marginal branch, it's very eccentric, but this is opposite. This is the opposite way of the carina shift. When you have carina shift, this is eccentric with a lesion which is toward facing the main distal vessel, the distal vessel. Here, the eccentric lesion is facing the proximal vessel, so it's typical of carina shift, of plaque shift. Sorry.
Okay, so I think so maybe after the stenting in the circumflex os, and then left main to LAD, and then I think so we can think about in the obtuse marginal branch later, and also carina shift usually is functionally is not significant, so maybe we can wait.
Okay.
I think you have to test it. This is a very tight lesion with some reduction in flow. So this is what we call a Rollerman side branch. This is a big side branch. If you leave it without touching, the patient will still have symptoms.
Okay, so I think it's okay. After that, maybe I can try to the obtuse marginal branch dilatation, but in the after the stent implantation in the circumflex os, maybe I'll try.
Okay, your major target is left main and LAD, so just focus on the left main LAD region.
스텐트 얼마짜리 넣을까? Okay, so I think
circumflex 3.5.
3.5. What? How much?
Length is short, 13.
Okay. So 3.5 in the is very short. In the 16. 더 짧은 거.
12.
12.
12.
12. Okay. Can
I will make a comment which is typical of an operator not doing frequently IVUS. Why not deploy a stent from left main to third?
Pardon?
I have always in my mind, I always try to reduce the number of stents, because the number of stents is also, in syntax, is also a prognostic factor. So I imagine that we can deploy a stent from left main to circumflex with protection of the LAD we have. Do a pot, after that look at what the remaining work.
But I think it's also LAD also is very critical stenosis.
What is next?
그럼 뭐야? 별로? 어디? 이렇게? 스텐트 발론을 한번 해야 할 것 같은데. 서크.
서크 스텐트 3.5에
12.
one more implant.
Would you consider removing the wire from the OM branch before stenting the osseous circ, or you're just going to leave the wire in the OM branch?
You will double gel this wire in the marginal. Do you plan to overlap or to do side by side?
The distal LAD, stent to the side, and okay, you're going to push another stent for the proximal.
Yes.
This is a wire twisting that we see here.
Maybe may need related
Maybe I
with
need some
kinking of a two
The
wire.
wires are twisted. We see it very clearly.
So
Dr. Han, remove the wire, OM wire. OM wire.
Dr. Han, would you want to treat big obtuse marginal branches or still compromise OM branches?
OM branch.
Do you want to
so-
treat or not treat?
I don't do, right now I think it's, maybe it's okay. Because it's somewhat cardinal shift in the, usually it's some, even maybe it's a determination by the FFR.
Maybe,
It is
maybe
not
not.
mainly a Carena shift. This is a plaque
I
shift.
think maybe not okay. Dr. Han, just kidding. Anyway, the wire in the obtuse marginal branch is prohibited, interfere the second stent, proceed proximal circumflexion. So I would like to pull the wire out and
Okay.
all right, you want to do your stent procedure proximal circumflex as you want.
Yes,
And then
yes.
wire gains if you want to treat OM branches, and it's more easier to approach, right?
테스트 한번 해볼까요?
테스트.
오케이. 그 발론 한번 더 합시다. 발론.
발론.
So I think it's before the stent implantation in the circles, and then maybe some more pre-dilated with the balloon. 발론 하죠.
지금 들어가 있는 2.5에 하나 더 드릴까요?
오케이.
2.5요?
Now, maybe stent could be closed.
Dr. Han?
Yes.
Initially we can see some much disease at OMOs. So I think you had a better.
OMOs,
Initially we can see some disease at.
initially we pre-dilated also marginal branch also before the stenting.
Okay. Cool. All right. You want to do balloon dilation first, right?
Yes, yes,
Okay,
yes.
2, 4, 6.
Deflate.
Deploy.
Okay.
Inflate.
More.
Deploy. 4, 6,
7, 8, 9, 10, 11,
10, 12,
Right.
14.
Deflate. 스탠 주세요. So I put the stent again, 3.012, 3.512.
Okay.
Okay, check angel. Okay, good. Obtuse marginal branch ostium looks better. So, do you want to place another synergy, short synergy stent?
Yes,
Is there any specific region?
3.512.
Is there any specific region you select synergy stent?
I'm not sure, but I think this is the observable polymer, so maybe it might be some complex procedure, some healing. The vessel, I think, is much more good other than the durable polymer second regulation stent. But I think it's it's not so big difference. But anyway, this time I put for this kind of thing in the synergy stent I choose. Test.
Great.
자, 엔지 한번 해볼까요?
Maybe.
Professor Park, what do you think about the position?
It's good.
So can we try? Okay, 갑시다. 자, in play.
Play.
오,
11,
Good.
12, 13.
13.
To play. 엔지.
Okay, very nice. Take another view.
자, 한번. 자, in play.
Sorry.
Actually, what size of balloons for the LED they mean?
This is for the just 2.5.
4.5?
2.5.
2.5.
2.5?
Yes.
6.
2.5.
7, 8, 9, 10.
Well, I think a little too small.
2.5.
Okay.
Too
Different.
small.
4.5. Maybe 2.5.
All right, Doctor, you want to crush, a balloon crush for
Yes, yes.
for the circumflex coaxial part, and so you may need a little bit, a bigger
Small
balloon.
size balloon.
All right, at
Okay.
least 3.5 something. Lastly, I was finding this clearly suggests its proximal LED is more than 3.5, almost 4.
Yes, so,
all right.
I agree with you, but maybe because we spent in the many balloons, so I just saved. But anyway, I think it's for okay.
Okay.
So LED는 얼마냐지? So I think the problem is that when we put the left main to cross over the circumflex source and the LED, because I think it's very big discrepancies diameter. So I think it's maybe we used in the 4.0 synergy stent, and then because proximal the left main distal to the shaft is almost 5.
Left main?
Yes,
Yeah, 4.5 to 5. 4.5 to 4.5.
4.5.
Proximal left main. shaft.
Okay, so I think as I put the 4.0 the synergy stent. How about the diameter?
4.0 by maybe 16.
16. I choose 16. Okay.
Totally depending on Dr. Hong,
Yes.
Gwangju, right? It's both.
So I think it's because he right now it's very good the suggestion on the information from the IBOS.
Marginal branch flow is getting better, and you chose the just a T stent or a small crash, mini crash.
Yes. So I think it's because we don't have any maybe I don't want is too much crushing.
From this angulation, the T stent or mini crash is one of good choice to use the two stent technique.
And Dr. Hikichi, do you prefer synergy stent for left main
Yes.
complex PCI? How
Yes.
about Japan?
Yes. Especially the synergy stent saturated situation is very good. The not 3.0, 4.0, 3.5 millimeter synergy stent expanded well, not expanded well, but 4.0 synergy stent expanded more than 5 millimeter.
So I think it's
Dr. An, check another view.
Yes.
Spider
Okay.
view may be helpful.
right because it's a spider. It's okay. Just
Very short main. Eh?
yeah. So I think it's maybe we don't have any good imaging. The other view. So 그리고 아래 코달 again.
Okay.
So test. Oh, so much.
Okay.
Great.
Check angio.
So I think good one.
So
It's moving. So okay.
if you can, took a floor, more
Okay.
clear imaging, is metal part, clear, right? Great. So
So I think it's okay.
I think
In plate.
Okay.
답답하십니다.
11.
Great.
Deflate. So I think I have to use in the NC balloon for the
Take care of your guiding. You have a gel wire, so you may have longitudinal
yes.
distortion.
Yeah, okay. Thank you very much. Angel.
Okay.
This view is good for the obtuse marginal branches.
Yes.
Not pretty much stenosis. I like this one.
Yeah.
Oh, wire, be careful.
레이드 와이어.
All right. Okay. Pull the wire out, circumflex.
밑에 볼까요? 밑에. Okay. So
Oh, no, it's LED.
Okay, Dr. An.
yes.
We'll check. We'll move to another room. Dr. Kim is waiting.
Okay.
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 So, Dr. Kim,
Hi.
can you hear me? Okay. Are you ready? And
Good
please
evening, everybody.
Yeah. Please
My name is John Kim from
Kim Juan.
Chonnam National University Hospital.
Dr. Kim Juan.
And it's a very honor to us for attending this live section in TCTAP. I introduce my team. It's my Joan Kim, and second operator is Dusan Sim, and third operator is Sung Shigo, and the IVE commentator is Yongcheol Kim.
So,
And
please introduce your case and approach, snapbox approach.
I just started to introduce the
Okay.
patient is Dr. Sim.
Good evening, ladies and gentlemen. This is a 57-year-old male patient who presented with effort angina. He had a history of hypertension, dyslipidemia, and he is a current smoker. His vital signs are stable, and his cardiac markers are negative. His exercise EKG test was positive, and his echocardiogram showed normal LV function without regional ball motion abnormality. His electrocardiogram showed no significant ischemic changes. He underwent coronary CT angiography at an outside clinic which showed significant stenosis in distal left main and mild stenosis in RCA. His baseline coronary angiography showed intermediate stenosis in the mid RCA, and there is significant stenosis in the left main stem and diffuse intermediate stenosis in the distal left circumflex artery.
So this case is discuss point is next slide. It's vascular access site of TRI or the TPI or RCA is angio guided or FFR guided. At the left main, it is IVUS guide or FFR guide, and stent steroid for the left main lesion.
Great. Yeah. 0.8. Okay. Please show us.
Discuss.
All right. Who is? All right. Okay. In my opinions, if I were I have these cases, I would like to approach a transradial, and right coronary arteries must be negative FFR. So you want to do that FFR first, and main disease is a quiet, visually tight stenosis, and I don't doubt too much about ischemic. Obvious guided. Treat or not treat concern, sometimes you need a FFR first. However, you decide to treat for this main disease. This is a very simple stent crossover, right? That is my opinion. Okay.
Thank you. And so, show the this area. Yes. 이쪽 좀 보여주실래요? 예. 카메라 좀 두 번째 카메라 좀 잡아주시고요. 예. We use the snub box punctures. This is left. Usually the left radial artery is very far the operator, but this is snub box puncture is very comfortable for the operator. This because in the my hand and near the left femoral puncture side. So we select the snap box puncture. And second is this ICA region is this FFI guide, and left main is this IVUS guide. This is plan, and so we first the FFI in the ICA.
Okay. So please show us a video of snapback puncture. We are doing a left main intervention through snapback puncture. Do you have a video recording?
Show me the slide.
Okay.
Learning curve is but very simple. Yes.
Yes, I'm Yongchol Kim, and the CNUH, we are starting the left snapbox approach from the November, it's the last year. So we've done with 150 patients via left snapbox approach, and for the coronary angiogram and the PCI. And this snapbox approach success rate is about 88%. And this oral patient, we performed the coronary angiogram via 6 French sheaths, and 100% is a success for the coronary angiogram via left snapbox approach. And regarding the PCI by the snapbox approach, is 97% is a success rate for the PCI via left snapbox approach. So as you can see, we compare with this snapbox and the conventional left radial artery diameter in the left downside. And the snapbox radial artery diameter is 2.5, and its conventional is 2.7.
So we do the FFR in the ICA, show the FFR imaging. FFR is 0.88, so we do not touch the ICA. But while we use it in the LAD, and we measurement the left main FFR is 0.8, and so we image guide PCI, so we want to the IVUS exam. Next time.
Can you see the IVUS image?
No.
Not yet.
No.
Not yet.
We cannot see. Okay.
Good,
Yes,
good.
play the pullback IVUS.
I was pull back. We cannot see that.
No, backward, please.
큰 화면으로 띄워주세요.
Yeah, so we've done this IVUS pullback from the proximal LAD with the D1 and the septal branch trifurcation. And here is you can see the eccentric calcified plaque, and here is the proximal LAD's body is relatively healthy. And here is the ostium of LAD. Circumflex is coming up. This is 7 o'clock. Yeah, here is the tight region, as Professor Park mentioned. And this minimal lumen area is 3.8 square millimeters, and the plaque burden is about 78%. And the distal reference lumen diameter is about 3.5, and the proximal reference lumen diameter is about 4.0 millimeter. So this is the summarized slide.
Okay, do you have OCT imaging?
Okay. This measurement is left main is 4.5 and the LAD is 4.0. So usually the strategy is the 4.0 stenting and the port with the 4.5 balloon. But usually this time we using the measurement of the OCT in the left main region. So we do the OCT.
So it's can you see it's OCT?
Yes.
Yes.
Yeah, it's a OCT. We pull back. It's beyond it's a trifurcation. So it's a plate OCT. So you can see the diagonal branch 2 and the septal branch 9. And as I mentioned, it's a relatively healthy area, proximal LAD body portion. And 6 o'clock is a calcium nodule is appear. And here is a tight region. It's a distal left main. And it's a left main shaft is relatively healthy. Yeah, this is the OCT pullback image.
Great.
And you can see it's a wiring. Yeah, we advanced the wiring into the ramus, and the 3D OCT reconstruction is definitely show the left circumflex ostium and the ramus.
Okay.
Main issue is measurement the IBUS is recommended the 4.0 stent with the dilation the 4.5 the ballooning, but OCT recommend this is 3.5 stenting and the balloon is 4.0. So
Dr. Hikichi, how about your opinion? Do you do OCT guide intervention for left main region?
Yes.
Okay.
Usually use and from the findings, I usually use the predilection just from the LAD to the proximal and the left main using the cutting balloon or NSE like low pressure balloon, and then I implanted just the 4 low pressure 4.0 diameter stent and performed proximal part using the POTS technique.
So you recommend 4.0.
Yes.
4.0 stent. Okay.
So, why did you do that, Dr. Kim? To be honest, we have very limited time. So, what would you do that? What is your plan?
We planned the recommended by the OCT. So we stented the 3 millimeter stenting and the balloon the 4.0 millimeter ballooning.
Great. In terms of minimal lumen areas by OCT 2.6 by IBUS 3 point something is clear matched with positive FFR. The cutoff value is 4.5 millimeter square. We published that, and so 0.8 FFR is very much gray zones. However, I clearly this case is more ischemic. That is our first concern. Treatment. Did you do the circumflex ostium IBUS too?
No, just the IBUS and the OCT is just
LAD,
the LAD,
right?
but circumference is
Okay.
intact.
For
But,
particular these cases, circumflex ostium by angiography is clear, it looks normal. However, in almost all cases, I recommended to separate, IBIS round, separate OCT rounds for evaluate the circumflex ostium. The reason why that some angulations can make some bias in terms of minimal areas and plaque morphology concerns. So, why don't you do that? You want to move? What did you do? Kim?
So
Stand?
Stenting.
setting
Stand.
direct
All right.
stand.
Why not?
Recommend the direct stenting
Direct
Okay.
stand. All
for
right, great.
the OCT.
All right.
Recommend.
So you can see in the bifurcation is left main. This plaque characteristics is relatively very vulnerable. It's called this necrotic core or lipid core plaque. So I would suggest it's direct stenting rather than the pre-dilation.
Great.
Okay.
That's
Which kind of stent are you
suggestions. So
Which kind of
we
stent?
need more data.
Yeah. What kind of stent do you select?
We select the giant stent.
Giants.
Giants, Shearer.
How about Onyx? Dr. Hikichi, do you recommend Giants?
The Giants, one
Okay.
of the option. The Giants stent is same design, 3.5 millimeter and 4.0 millimeter. So this situation, I will choose the 3.5 millimeter, maybe.
Let's try the stenting. Yes. Test. Okay. 앉아. Yes. Test.
How about position?
Test.
Why do you remain the wire in the lammus branches?
Okay.
Just the protection, the limus.
Protection?
Protection. Yes.
All right.
Okay.
Test. Okay. Spider.
Recently, anyways, angiographically not, disease-free branches.
Yeah.
I don't want to do complex wire placement, just a single wire. It's quite good osteal lammus branches, and so, okay.
Impression.
According to OCT finding, ramus, ostium, and circumflex ostium is intact.
Impression. 자, 앉아요. 자, 뷰 바꿔볼까?
Good.
이쪽 뷰 바꿔주시고요. 네. 앉아.
Okay. So, do you want to follow IBUS or OCT?
Balloon in the left main, using the 4.0 balloon,
Okay.
and then it's OCT follow.
OCT? Why? IBUS is better than OCT for big artery.
But technology is available the left main region using the OCT this time.
Do you want a wiring again?
Yes.
Where?
I would have,
Okay.
personally, I would have done a pot
Alright,
before
right,
exchanging the wire.
You may not, you may not need that, right? It's very good, not too much compromise, it's absolutely normal, as you did. You're gonna do just a high pressure inflation for that, right?
This radial snapper function is very convenient for patients, so it's very useful currently in our case lab, even in left intervention.
Yeah, we've done with the snowbox approach for the full STEMI patient, and we used the glyco-2b3 inhibitor and the new P2Y12 inhibitor loaded. And after PCI, there is no hemostasis complication in the puncture site.
Okay. And we can save radial artery even in patient or CKD patient underwent hemodialysis.
11, 14, 16, 16.
Right?
앉아.
그래요? Okay. Okay.
Okay, very good.
I think it's great angiographic, result. Dr. Kim, thank you for joining us, and congratulations, it's excellent lab cases. We want to move Dr. An's cases for briefly.
자,
Dr. An?
시작합시다.
Okay.
Yes. So I think
Right
we
away.
already the left main proximal is 4.5 NC balloon, high pressure inflation, and then we're rewiring. And the right now is I'd like to making some kissing balloon.
Great.
한번 가볼래?
Ooh.
Okay.
Okay. So
Inflation.
2,
4,
5, 6, 7, 8,
7, 8.
9, 10.
What size balloon?
13, 14. So for the 2.5 NC deflate, for the circumflex artery, and the 3.0 balloon for the LAD. 1, 2, 3, 8. Okay, 8,
4,
5, 6, 7, 8.
7, 8.
Great.
Okay.
Deflate.
Okay, so all right, final.
Okay. 잠깐만. 앉아.
Perfect.
Okay. Beautiful.
Okay. Even
So I think I will making some IBUS examination.
right. Anyway, Dr. An, thank you for
Yes.
joining us. Really, nice case presentation. Even big obtuse marginal branch, it looks good. Totally, good result. Thank you for, joining us.
Okay.
Right.
Thank you very much.
Thank you.
Okay.